I'd like to introduce Dr. Kate Otto Chebly, who I've known for many years at NYU Medical School. I knew her as a student, and now she's finishing her training in uh, family health and moving to Venezuela, where her husband is from. And she's a writer too, who did a book, a wonderful book called Everyday Ambassador. Welcome to Conversations with Shem. Our focus is to show how to put the human back into healthcare.
Welcome to another episode of our show. Today we are going to be listening to a conversation between Dr. Samuel Shem. He's the author of The House of God and Man's Fourth Best Hospital and the professor of medicine and medical humanities at NYU Grossman Medical Center. And across from him virtually is going to be sitting Dr. Kate Otto Chebly, who is the NYU Chief Resident of Internal Medicine and Primary Care, and also the author of Everyday Ambassador. So welcome to you both.
Thank you. Thank you. Well, this is a great pleasure for me. I knew Dr. Kate as Otto, Kate Otto. Now she's married and has taken Otto Chebly. When I think you were, what, a third-year student, maybe, something like that?
Yeah, I think it was
Way
my
back,
last
a while ago, third-year student at NYU Medical School, and she was just marvelous, a marvelous person to get to know, wise beyond her years. And she has just been working to provide healthcare for really difficult patients at Bellevue. And she was in our writing group. Some of the other people have been on this podcast from there and tried as hard as she could to get there, but the two kids, et cetera, and a bad job were different. So anyway, I'm delighted to have you here, and we'll just talk. And you know, the thing that we both are very interested in really are two questions, I think. One is what's inhuman about healthcare in the United States now, and what do we do about it, basically? And what do you think?
Well, thank you very much for making the time for this conversation. I know we've had many conversations. I remember pre-COVID in the big cafeteria at the NYU hospital talking about just this topic. And, you know, when I think about what's inhuman about medicine and the healthcare system, I have to think, well, what does it mean to be human? And for me, that's a lot about the interactions you're having with other people. So if I was thinking about what's inhuman right now, as a practicing physician, I think about three different kind of interactions. So with my patients, with my colleagues, and then with myself and my family. And I think at each of those levels, there's really a lot of improvements to be made right now in the way our systems run. So for example, as someone who focuses on primary care, as you know, as we can all imagine, the short time I'm given to actually interact with a patient is not enough for how complex an average person's needs are. So of course we're there to take care of chronic illness like hypertension and diabetes, asthma. But of course people's lives are so complex, especially in the wake of COVID, economic instability, traumas at home, in people's lives. There's a lot to work on, and a lot that happens in other people's lives that affect their health and their medical care. But that does not reflect in the way that I'm encouraged or allowed to spend time with patients, or it's not perhaps reimbursed the same way that a formal procedure or test is, even though those conversations that we have might actually be even more essential to their health and well-being. So I think about the kind of environment and time in which I spend time with patients, and I think that I would love to see optimized. In terms of with my colleagues, the reason I kind of wanted to bring this up is, this year in particular has been a year where healthcare workers have been like always stressed, but of course above and beyond with COVID and the demands it's put on us. And something that's been a long time coming, but coming to terms with a lot of the discrimination that happens in the workplace and against people based on race or other reasons. And so, the reason I say it matters for us to have good interactions with our colleagues, and that's what can be inhuman sometimes, is for example, in our residency program this year, we actually instituted an anti-racism curriculum this year where we meet every 6 weeks and we'll discuss some topic within it. And, as someone who does not experience racism myself, my eyes have been opened to a lot of experiences I wasn't even aware that a lot of my colleagues were having. And this idea of how we work in a system that we sometimes don't even see the ways our colleagues are suffering and struggling. So that's another area for improvement, is finding work environments that are more human.
What did you come to realize that you didn't before in people of color that you treat?
That I treat or that I work with, or I guess both, probably.
Yeah, both.
So I think probably what I didn't appreciate so much is that, for example, I'll give you one example. Now that the COVID vaccine is available, I have some patients from the Black community who are hesitant of getting the vaccine. And if I spend time and listen and hear the full reasons why someone is really hesitant, it makes a lot of sense. It makes a lot of sense in a system where someone has not taken their complaints seriously, and that has sometimes led to worsened medical care, for them to just suddenly want to believe that the system has its best interests in mind. And as someone who hasn't had those struggles with the healthcare system, or hasn't had to think about, do I trust or do I not trust this doctor? Do I trust or do I not trust the system? I didn't have the experience to know how that feels. And so kind of this conference we're doing is meant to be an empathy building conference to better understand other people's experiences, so that you might appreciate when a patient brings a concern to you about the lack of trust in a system, that maybe I, as an individual, maybe I don't feel like I'm perpetuating distrust every day, but I'm certainly part of a system that has not been reliable and responsible, and having to rethink, how I listen, how I give care, how I hear what people's concerns are.
And what would you say the main reason that they're reluctant to get vaccinated is?
Well, there actually hasn't necessarily been a main reason. Everyone, to be honest, the few different people who have been hesitant have all kind of had different concerns. And they range from, some people being afraid that the outcome of the vaccine would be worse than the outcome of getting COVID itself. I had a patient who had said one of her friends got very ill after getting the vaccine, and other people just kind of generally distrusting pharmaceutical companies and medical institutions. So kind of a wide range, and from all backgrounds, not just from patients from the Black community, but just as an example.
Mhm, mhm. And what else? What else in terms of understanding the inhumanity?
Oh, and so patients, colleagues, and then with the reason the last piece of ourselves is that again, as we know, medicine can be a career where starting from residency, work demands are enormous, and it is not uncommon for people to put aside their personal life, their family life, anything outside of medicine, in pursuit of those kind of career goals, or during residency, the actual expectations and requirements. And over time, that can be really destructive if you don't have space for yourself, your development, if you want a family, your family. And so I think that creating, ultimately, I guess the way this connects to patient care and medicine is that if we're the ones counseling patients to, eat a healthy diet and rest well and have
Good luck, right? Good luck.
yeah, have good fulfilling relationships, and then we can't do any of those things. Like, yeah, what are the odds that we think we should be practicing what we preach if we think that it's important for people to have fulfilling lives. You of course, medicine is a heavy profession and a lot comes with that, and you need to take seriously the work every day. But it can be done that you have a fulfilling career and work and work spaces in which you also are able to have a life outside of that that's meaningful to you and refreshing and fulfilling to you.
So how many years, when did you start medical school and now you're finished? And how many years was it all told?
So at NYU, I was part of a program called the 3-year MD
Okay,
program.
great. Yeah.
So normally a medical degree is 4 years, and I was in a 3-year program that fast tracked into the primary care residency program. So 3 of medical school and 3 of residency, and currently in chief resident year.
Uh-huh. And you told me you did a lot of Zooming for to treat patients in outpatient anyway from home. So that must have been kind of a gift to be with your family and not have to run back and forth every day, you know.
Yeah, it was interesting because right as COVID was really starting to become clear in New York City how serious it was going to become, I was 8 months pregnant, working in the hospital, every day. At that time, nobody was wearing masks anywhere.
Oh,
We
oh,
just didn't know anything at the time. And so it all changed pretty quickly, but within a couple of weeks, we had kind of redeployed all of our residents in different capacities, and myself and 3 other residents who were also very pregnant, all basically took over the outpatient clinic, and which had also kind of closed to in-person visits, but was running telemedicine operations. So we all basically took over the panels of all of the resident physicians and did all of the televisits. So it was definitely, amazing to be in a supportive workplace where I was able to still work, but in a way that I felt was safe for myself and my family. But wow, I mean, the telemedicine that was happening at that time, as you can imagine, we were still kind of learning and figuring out what protocols were and how to best counsel people, figuring out kind of, keeping people out of the hospital at all costs.
yeah.
But knowing what the line was when someone did need to go to the hospital, and taking that very seriously. It was an heartbreaking time, interesting time. But it was also, it was wonderful to not have a long commute and be able to spend more time with the family. And since then, telemedicine has remained a big part of primary care, at least in my practice. So all of our residents now do part of their primary care is telemedicine.
Yeah, I think that's a good change too.
Yeah. And I think it's been, I think there's a lot to say about health equity in telemedicine. For sure, there are some reasons why perhaps equity is harder to achieve with telemedicine if there are certain groups that don't have access to either the devices or the connections or the privacy needed to make use of it. But that said, I also do for sure have some patients who otherwise would have had a really hard time getting into the clinic because they work a couple of jobs or because they live farther away. And now we can connect more often.
I want to the people listening or watching actually don't know that you have served for me in the cafeteria. No, you don't serve food. You have served me in the cafeterias, which I use as my office at NYU Med, for helping me to understand modern medicine right from the start of man's fourth best hospital. Because as you know, I wasn't taking care of patients, and I went and I watched and stuff, and you were just such a wonderful model and teacher about what's going on. In fact, maybe I took some of your characteristics and words and put them in. I won't admit it, but anyone who wants to read it, you'd be a good model. But as you know, you read every page before it came out. As you know, I got all stirred up because of two things that I said, hey, wait a second, these are unjust things in medicine, in the whole system of medicine. And as you know, the book starts with Roy Bash saying he's in Costa Rica, and he says, I have to write about this when medicine could either go one of two ways, either toward more humane treatments or toward money and screens, which means money and money, since the screens, as we know, you've been right on the front line there, are billing. And that, as I think you probably agree, has caused a hell of a lot of problems all up and down the healthcare industry. And the fat man gives this lecture of the 6 rackets of American healthcare, follow the money, because I had to really understand it, and it took me 2 months to understand it. And it's all about money. But the question is, and he tried to provide an answer at the end, what do we do about this? Because doctors are hurting, patients are hurting, everybody's hurting except the people who are in it for the money. So what would you say at this point about that? About screens, meaning computers for billing, and about how that affects the whole patient interaction, and about the incredible disparities?
Sure. So I think I probably don't know enough about the details of how the billing works to make any big statements there. What I will say is it's really important for any electronic medical record system to be built in a way that is primarily for the physician to be able to better understand what's going on with the patient. And thankfully nowadays that they are built such ways for the patient to be able to access their own information, data, and be able to communicate with a physician. So I don't really know enough about the evolution of how that's changed, and perhaps how that's even changed over the course of COVID on the design side of them. What I will say is that I have utilized the electronic medical record in a different way over the past year, in the sense that especially during the COVID surge, when I suddenly was seeing a lot of patients who were not my patients, who I didn't know, it was very valuable to be able to quickly access a lot of information about them that otherwise would have been really difficult to get if it were not online and organized in that way. And it's also been really wonderful. We started off kind of doing audio only visits because that's what was available at the time. And one thing that has been kind of built into our medical system, at least over the past year, are video visits, which were not there at the beginning, but are there now. And that has been for a subset of my patients has been amazing. And the reason why it's been so great is because, as you can imagine, doing a video visit with a patient, it's almost like doing a home visit, which is something I used to do in the pre-COVID days with my patients. So, you can see, as long as it works for the subset of patients who live in a environment that is either, private enough for them to be able to do a video visit, or who live with people who are involved in their healthcare and are happy to, and everyone is okay with them being involved in that video call. But, meeting caregivers, meeting other family members, seeing if there's anything concerning in the home that you can help out with, having someone show you their medication and how they use it and whether it's right or not. Those are all really helpful things that were harder to do if it was an audio
Well,
only interaction.
But, in terms of how they pay for it, we haven't mentioned Bellevue. You've done all of your medical school training at Bellevue, right? Which is a huge, 800 bed public hospital. It's one of the biggest it's the biggest in New York, and it's a city hospital, and one of the biggest in the country, of course. And the payment, there's very, very little private insurance payment with those people, right, that go there.
I don't know the exact numbers. The last information I heard was something along the lines of a quarter kind of, self-pay, largely, undocumented, no insurance, a quarter private insurance, a quarter, and then the rest is some type of Medicaid.
Right.
There's different types of Medicaid that reimburse.
Right. So you've seen both sides because you've trained at for-profit hospitals at NYU. Mm-hmm. So is it true that your burden of being in front of the screen because of for-profit hospitals is harder and more hours per day than it is at a public hospital like Bellevue? Is it easier at Bellevue for you and less time consuming? Because that's a big deal. I mean, my model, although I've never worked in one for any length of time, is the VA system, because, an appendectomy in one place in the United States is paid by the national insurance the same as everybody else. So you're not arguing with the insurance people. So what do you think about that? Is it easier in where you have done your really heavy training, last big training?
Yeah, I did. Majority of my training was at Bellevue, but also had time at the VA and had time at NYU. So,
right. Well, go for it. I've been waiting for your expertise, my dear.
Not quite expertise, but what I will say is that so I think that whatever system you have in front of you, at least in my experience, you have to just make the most of what it is. You'll probably hear different answers from different people, but so Bellevue and NYU are actually on the same medical record system, which is called Epic.
Right.
And so it's a similar kind of process that you're going through. And at the resident side, you learn one and you can use both systems. And I guess your question was, is that
easier? The question is, if most of your payment is in Medicaid, you don't spend nearly as much, this is my thesis, you don't spend nearly as much in hassling with the insurance who doesn't want to bill that much, or people in the hospital calling you and saying, well, no, that's sepsis and it's always coded severe.
I see what you're saying. So on the inpatient side, there's actually a bit of protection at the resident level, at least. I'm not sure what it's like from an attending level. And no matter how my patient is insured or not insured, my experience is essentially the same in terms of ordering things, obtaining tests and exams for the patient. On the outpatient side, so I only work in the public hospital system on the outpatient side. What I will say, this is less about the electronic medical record, but what I will say has been one of the most frustrating parts of moving into a primary care career is that based on different insurances that my patients have, when I order a medication for them that I know they absolutely need and are qualified for and have met the requirements for, and then I need to fill out, and then I get a message back saying, this needs a prior authorization, you need to jump through these hoops and call this number and this, that results in a delay of care. I just had a patient the other day And I won't say anything about the patient's individual identity to protect them, but essentially someone with diabetes who had been very well controlled on a certain medication regimen. The insurance company stopped covering one of those medications. She was confused about that process and essentially lost access to that medication, had a difficult COVID year and was falling out of medical care. Essentially now she's has very uncontrolled diabetes. And in getting this patient back on the medications needed, it's been very challenging and time consuming, not just for me. I'm happy to do whatever work is required, but for the patient, this patient has to wait. And that's time ticking away that this patient's not getting the care they need. So that to me has been very frustrating, because if someone needs a medication to treat a condition that they have, that is a common condition, and it is a no medication, and perhaps I don't know enough about the economics of it, but it doesn't make sense why these authorizations take up so much time. And it's only for certain patients. It's only for patients with certain types of insurance, and others don't have to deal with that.
Let's shift quickly, because we're almost out of time.
Oh, wow.
To sunny Venezuela. Two questions. Are you going to keep doctoring, and how and where? Number two, are you going to start up writing when and where? We need you.
Great questions. So yes, my family and I are moving to Venezuela this summer. My husband is from Venezuela, and I will be able to practice there. So I'll have to obtain my credentialing before I can practice, but the goal will be to continue practicing primary care there. It is a very complicated country with a lot going on right now, and for sure a lot of need for medical care. So I'm sure there will be opportunities.
So are you going to work in the government, or are you going to work a government hospital or a private hospital?
I don't have any specific job lined up at the moment. My goal is to get there to better understand the different hospitals, the different systems, how the health ecosystem works, and to try to figure out where I can be most helpful. So in the meantime, there will be lots of time for writing in the meantime, as we're waiting for that. So yes,
the medical ambassador in Venezuela.
Yeah, for sure. But per the ethos of Everyday Ambassador, my first book, I believe very much that it's important as although my in-laws are there, my family's there, I am not from there. And I think it's just very important to get to know a place, understand a place, understand where you're best positioned to be helpful before starting to try to help. So there'll be a phase of getting to know, and I'll be sure to get a lot of writing done during that phase.
I think a line comes to me at the end of this with, after all we do is help walking others home.
I like that. I like that very much.
So thank you so much.
Thank you too.
That was a wonderful exploration of what American medicine is now by a wonderful doctor who has worked, she would never say it, worked in one of the most difficult frontline family practices in America for sure, which is at Bellevue Hospital and New York University. And she's a gem, and she's also a writer. And I loved hearing how she was able to concisely talk about all different things in medicine, from a particular patient to what it's going to be like in Venezuela, where she's moving.